Dr. Cox here, and in this session we're going to talk about the basics of aortic imaging. Primary topics that I would like to touch on in this session are satisfactory imaging technique, thoracic aortic aneurysm assessment, acute aortic syndrome along with the different diagnoses and types, treatment, and potential complications associated with acute aortic syndrome. Aortic imaging techniques are important to follow to adequately assess for aortic disease. In this session, we're going to talk exclusively about CTA imaging of the aorta. You can also image the aorta with MRA and ultrasound, although those are generally for surveillance. For CTA imaging, it's important to first start with a non-contrast study. This allows for evaluation for intramural hematoma. Then in the contrast phase, you're going to bolus the contrast so that it's dense within the aortic arch and branches. And you're also going to gate the study, meaning apply an EKG to the patient and then match the imaging with the cardiac cycle to remove cardiac motion from the ascending aorta. You'll continue the study throughout the entire aorta to the level of the iliac branches. In assessing the aorta, the first thing is to note the diameter, because we're going to be assessing it for aortic aneurysm. There are a lot of numbers out there in terms of what is the expected diameter of the aorta, and you can also assess it based on male versus female. But to kind of keep it simple for you, I think these are three useful numbers to remember. That the definition of an aneurysm is when the diameter reaches 150% of the expected diameter. And then what point for the diameter of the aorta is it considered abnormal? And for the ascending aorta, a diameter of 4 centimeters is considered dilated. And then in the descending aorta, 3 centimeters is considered dilated. So on to acute aortic syndromes. There are 3 primary types. And I would like at this point to separate out acute traumatic aortic injury. I talk about that in the trauma discussion, and that's a different disease. In the acute setting, when you have aortic injury, that is a surgical emergency, as opposed to acute aortic syndrome, where they're presenting outside of the setting of trauma with an abnormality of the aorta that will then be assessed for how to treat it. So the first diagnosis to discuss with acute aortic syndrome is intramural hematoma. And in this image, we've got a non-contrast example of the aorta, and then the white arrow demonstrating a hyperdense crescentic abnormality surrounding the ascending aorta. And that surrounding hyperdensity is actually blood. And that blood is sitting within the vessel wall, which has gone through an intimal defect and extended within the wall, and why we call it an intramural hematoma. On the contrast portion of the study, if there is demonstration of an outpouching of the expected lumen of the aorta beyond the normal margins, this is called a penetrating aortic ulcer. You can see this both in the acute setting and then also following that acute setting. So you could have a patient that presented with chest pain that has a penetrating aortic ulcer as the cause. But you also could have a follow-up CT performed that demonstrates an ulcer, and it's not necessarily acute. This does extend through the intima as well, and has risk of progression. And then finally, dissection. In dissection, as opposed to intramural hematoma, there is a proximal defect in the intima, and as well as a distal defect in the intima. And this creates both a true and false lumen. So here the T is labeling the true lumen of what would be the expected path of the aorta, and then the intima, the intimal flap, and then lateral to that in the ascending aorta we see here the false lumen. All three of these run the risk of progressing on to potential rupture. So those are the diagnoses of acute aortic syndrome, and now it's useful to differentiate those into the different types, and we apply the Stanford criteria, where Stanford A is anything that includes the ascending aorta, and in general this is a surgical abnormality, as opposed to a Stanford B, which excludes the ascending aorta. So anything beyond the brachiocephalic artery is technically a type B Stanford, and is generally treated as with medical treatment, like control of hypertension. There are cases in the ascending aorta in which you may try to manage it medically, such as penetrating ulcer or intramural hematoma, and taking into assessment whether the patient is a good surgical candidate. So what are the complications that can be associated with acute aortic syndrome? First is that you will watch these abnormalities over time and see if they progress. In this example, we have a small intramural hematoma adjacent to the ascending aorta, and overall that entire aortic diameter to include the intramural hematoma measures 4.9 centimeters. On a follow-up non-contrast chest CT that was obtained for shortness of breath, we now see that the overall ascending aorta measures 5.6 centimeters. We can faintly see the high density of an intramural hematoma associated with that, but now we also see in the descending aorta an additional hyperdense crescentic intramural hematoma. So this is progression of the initial ascending aortic abnormality in this patient who is a poor surgical candidate. And then this runs the risk of future rupture. In the setting of an ascending aortic aneurysm, it can also extend to the aortic root, and in doing so threaten the origins of the coronary arteries as they come off of the right and left coronary cusp. As you see here in this example of an ascending aortic aneurysm with a large false lumen, the right coronary artery coming off of the right coronary artery cusp is very attenuated and irregular because the dissection itself has now compromised the origin of the right coronary artery, likely with dissection extending into that artery. From the aortic root, it can then break into the pericardial space, and in that setting create a pericardial hematoma, as you see in this patient, with a large amount of high density fluid surrounding the heart and compromising the diameter of the right ventricle. It is a physiologic phenomenon to discuss pericardial tamponade, but you would want to raise concern for tamponade in this patient. Also, along with involvement of the aortic root, you can have compromise of the aortic valve. In this patient, we see a descending aorta with a small defect representing an penetrating ulcer, although we have surrounding high density, which is extending even beyond the expected margins of the aortic wall into the mediastinum, with high density layering in the pleura. And this is actually an active rupture of the aorta in the setting of acute aortic syndrome, and that this is a life-threatening event. So that is the tour of thoracic aortic imaging as far as basics for an introduction, and thank you very much.